Welcome to our comprehensive guide on managing medically compromised patients in oral surgery. Understanding a patient's medical condition is crucial for safe and effective surgical care. Before any procedure, practitioners must gather a detailed medical history to assess both general and physical health. This information forms the foundation for preoperative and postoperative management, ensuring that every patient receives personalized care. Remember, the golden rule is, know your patient well and never treat a stranger. This approach minimizes risks and helps anticipate potential complications, setting the stage for successful outcomes in oral surgery. In 1962, the American Society of Anesthesiologists introduced the ASA Physical Status Classification. This system helps identify the medical risk for patients undergoing surgical procedures. It ranges from ASA 1, indicating a healthy patient, to ASA 5, describing a moribund patient, not expected to survive 24 hours. Emergency operations are marked with an E prefix. This classification is essential for oral surgeons to evaluate whether a patient can safely tolerate a planned procedure. Thorough risk assessment includes understanding the nature, severity, and stability of the patient's condition, their functional and emotional capacity, and the specifics of the planned surgery. Risk assessment is a cornerstone of managing medically compromised patients. Surgeons must evaluate the nature, severity, and stability of the patient's medical condition, functional capacity, emotional status, and the type and magnitude of the planned procedure are all critical factors. For example, invasive procedures, lengthy operations, or those with significant blood loss require extra caution. The use of vasoconstrictors and the patient's tolerance to stress must also be considered. By systematically assessing these elements, practitioners can tailor their approach, minimize complications, and ensure safer surgical outcomes. Stress reduction protocols are vital for medically compromised patients. Effective communication about fears and concerns helps alleviate anxiety. Scheduling short and morning appointments can reduce stress and fatigue. Preoperative sedation with short-acting benzodiazepines, such as triazolam, is often recommended. Intraoperative sedation with nitrous oxide and oxygen, along with profound local anesthesia, ensures patient comfort. Avoiding postural hypotension and maintaining constant verbal contact during treatment are important. Limiting epinephrine use to a maximum of 0.04 milligrams further reduces risk. These strategies collectively create a safer environment for both patient and practitioner. Preventing hypoglycemia and fatigue is essential in oral surgery for medically compromised patients. Adequate postoperative pain control, proper contact, and follow-up are key components. Ensuring the patient has eaten and is not fatigued before surgery helps maintain stable blood sugar levels. Post-operative monitoring and pain management reduce stress and promote healing. These measures are especially important for patients with diabetes or those prone to hypoglycemia, as they help avoid dangerous fluctuations in blood glucose and ensure a smoother recovery. Cardiac diseases present significant challenges in oral surgery. Patients may have congenital heart disease, rheumatic heart disease, ischemic heart disease, or require prosthetic valve replacement. Hypertension is also common. These conditions increase the risk of complications during surgery, especially under general anesthesia. Unstable angina, congestive cardiac failure, valvular defects, and recent myocardial infarction are particularly high risk. Surgeons must weigh the benefits and risks of anesthesia and surgical intervention, considering the patient's cardiac history and current status. Before oral surgery, cardiac patients require thorough preoperative investigations. These include chest radiographs, electrocardiograms, echocardiograms, and stress tests. Blood investigations such as lipid profile, bleeding time, clotting time, and prothrombin time are essential, especially if the patient is on long-term anticoagulants. These tests help assess the patient's cardiac function and risk, guiding the surgical team in planning safe procedures and anticipating potential complications. Patients with rheumatic heart disease or prosthetic valves require antibiotic prophylaxis before surgery to prevent infective endocarditis. If the patient is on regular Penadura injections, surgery should be scheduled immediately after the dose. This reduces the risk of infection and ensures optimal protection. Proper medication management is critical for minimizing complications and safeguarding patient health during oral surgical procedures. During and after surgery, cardiac patients must be closely monitored. ECG, pulse oximeter, and arterial line are used to track vital signs. Intravenous cardiac drugs are administered until oral feeds are possible. Fluid overload should be avoided, especially in congestive cardiac failure, and central venous pressure is monitored. For patients on anticoagulants, local measures are used to control bleeding, and drug therapy is adjusted as needed. These steps ensure patient safety and reduce the risk of cardiac complications. Managing patients on anticoagulant drugs requires careful planning. Indications include deep vein thrombosis, pulmonary embolism, rheumatic heart disease, atrial fibrillation, stroke, and prosthetic heart valves. Oral anticoagulants interfere with vitamin K-dependent clotting factors, affecting bleeding and clotting times. For minor dental procedures, anticoagulant therapy is usually not withdrawn. If therapeutic levels are not achieved, patients may be shifted to intravenous anticoagulants like heparin. Monitoring PTR and INR is essential to guide dosage and timing of surgery. Protocols for treating patients on anticoagulants include obtaining a proper medical history, confirming drug dosage, and checking PTR and INR levels. Antibiotic cover is recommended, and appointments are scheduled once desired therapeutic ranges are achieved. Dosage adjustments are made based on PTR and INR values, with invasive procedures delayed if levels are too high. Physicians are consulted for dosage modifications, and atraumatic surgical techniques are used to control postoperative bleeding. Anticoagulant dosage can be regulated back within 48 to 72 hours in consultation with the physician. Antiplatelet drugs, such as aspirin and clopidogrel, inhibit platelet aggregation and increase bleeding time. These medications are used in coronary artery disease, post-myocardial infarction, and unstable angina. Prior to oral surgery, platelet function analyzer and IV bleeding time tests are performed. If bleeding time is prolonged, aspirin may be discontinued for 3 to 5 days to allow new platelets to enter circulation. Understanding the effects and timing of antiplatelet drugs is crucial for safe surgical management. Patients with congenital heart disease face risks such as infective endarteritis and prolonged bleeding. Bleeding problems may arise from right to left shunting, thrombocytopenia, or lack of coagulation factors. Proper antibiotic prophylaxis, avoidance of dehydration, and testing of bleeding and prothrombin times are essential before any surgical procedure. Consultation with the physician is recommended if these times are prolonged, ensuring safe and effective management. Rheumatic heart disease patients are at risk for infective endarteritis. Management includes antibiotic prophylaxis with 2G amoxicillin 1 hour before the procedure. Patients on daily or monthly penicillin should continue their medications to prevent recurrent attacks. These steps help reduce infection risk and ensure safe surgical outcomes for patients with rheumatic heart disease. Ischemic heart disease and angina pectoris require careful management in dental settings. Stress and anxiety can precipitate anginal attacks or even myocardial infarction. If chest pain occurs during treatment, stop the procedure and administer nitroglycerin. Monitor vital signs and provide up to 3 tablets within 15 minutes. If pain persists, transfer the patient to emergency care. Stable angina allows routine dental care, while unstable angina requires termination of the appointment and physician notification. Avoid vasopressors except limited epinephrine in local anesthetics. Managing angina patients involves reducing stress, scheduling morning and short appointments, and using pre-medication like diazepam. Prophylactic nitroglycerin and nitrous oxide sedation are recommended. Effective local anesthesia with limited epinephrine is safe. Staff should maintain a warm, concerned approach, encouraging patients to discuss fears. These measures help prevent anginal episodes and ensure safe dental care. Patients with acute myocardial infarction should not receive routine dental care for at least 6 months due to increased risk. Consultation with the physician is essential. Schedule morning and short appointments and terminate procedures if the patient becomes fatigued or develops symptoms. Use local anesthetic with limited epinephrine and pre-medicate with diazepam to reduce stress. Adjust anticoagulant therapy as needed and avoid stimulating the gag reflex. Monitor blood pressure and avoid instruments that may interfere with pacemakers. Patients with prosthetic heart valves are at risk for endocarditis and prolonged bleeding. Antibiotic prophylaxis is given for all dental procedures. If scaling or surgery is planned, anticoagulant dosage should be reduced by the physician so that prothrombin time is twice normal or less on the day of the procedure. These precautions help prevent complications and ensure safe surgical outcomes. Hypertension is defined as blood pressure above 140/90 mm Hg. Uncontrolled hypertension increases anesthetic risk and causes excessive bleeding during surgery. Preoperative investigations include chest radiograph, ECG, kidney ultrasonography, ophthalmic evaluation, and renal function tests. Blood pressure must be controlled within normal limits before surgery, and antihypertensive medications should be continued. Continuous monitoring during and after surgery is essential to prevent complications. Management of hypertension involves monitoring blood pressure, continuing antihypertensive medications, and supplementing potassium if diuretics are used. Local anesthetics without adrenaline or bupivacaine are preferred to avoid cardiac effects. Stress and anxiety can elevate BP, so stress reduction protocols are employed. Excessive use of vasopressors is avoided, and sedative medications are used cautiously. Referral to a physician is recommended for medication adjustments and if BP is significantly elevated. Lifestyle modifications are recommended to manage and prevent high blood pressure. Maintaining normal body weight, reducing meal portion sizes, limiting calorie-containing beverages, and decreasing dietary fat are important. Increasing intake of fruits, vegetables, and low-fat dairy, reducing salt, engaging in daily aerobic activity, and limiting alcohol consumption are also advised. These changes help control hypertension and reduce surgical risks. Respiratory diseases are categorized into obstructive and infiltrative types. Obstructive diseases include asthma, chronic bronchitis, pneumothorax, and emphysema. Infiltrative diseases cause inflammation in alveolar walls. Any respiratory disease is characterized by dyspnea. Patients with decreased pulmonary reserve are at high risk under general anesthesia. A thorough history of smoking and tuberculosis is essential. The main concern is the patient's ability to tolerate anesthesia and maintain respiratory function during surgery. Management of respiratory diseases includes preoperative investigations such as chest radiograph, pulmonary function tests, blood gases, and sputum culture. Patients are counseled to discontinue smoking and treated for acute infections. Bronchodilators are used pre, intra, and postoperatively, and inhalers must be available during emergencies. Arterial blood gas monitoring is performed during and after surgery. Fluid overload is avoided, and blood loss is replaced with packed cells to maintain oxygen carrying capacity. Bronchial asthma is a chronic inflammatory disorder with episodes of chest tightness, coughing, and wheezing. Safe dental treatment depends on pulmonary function, risk of acute episodes, immune function, and adrenal status. Prevention of sudden airway obstruction is essential. Elective surgery is performed only on asymptomatic or well-controlled patients. Dental materials and products can trigger asthma, so practitioners must be vigilant. Immune status and corticosteroid therapy are considered for antibiotic prophylaxis and steroid replacement. Asthma management is divided into before, during, and after treatment. Before treatment, assess risk level, frequency, and severity of episodes. Confirm medication use and ensure inhaler availability. Appointments should be scheduled in late morning or afternoon. During treatment, have bronchodilator and oxygen ready. Use stress reduction protocols and avoid triggers like improper suction, fluoride trays, and cotton rolls. After treatment, monitor for complications and provide supportive care as needed. Renal diseases such as renal failure, glomerulonephritis, and nephrotic syndrome pose significant surgical risks. Disturbances in renal function affect acid-base balance, calcium, phosphorus, and electrolyte levels. Chronic infection may lead to sepsis postoperatively. Fluid retention and hypertension are common, and patients may develop anemia. Preoperative investigations include renal profile, creatinine clearance, serum calcium and phosphorus, urine analysis, and imaging studies. Intra- and postoperative management of renal disease includes monitoring fluid, acid base, and electrolyte balance. Renal profile tests are performed during and after surgery. Blood replacement is done with washed packed cells, and potassium overload is avoided. Broad-spectrum antibiotics are used to prevent sepsis, with amoxicillin, doxycycline, and minocycline recommended. Dosage adjustments are made based on renal function to ensure safe and effective treatment. Hepatic diseases, including chronic alcohol intake, substance abuse, and viral hepatitis, affect drug metabolism and clotting factor synthesis. Patients with hepatitis B or C pose a risk of transmission. Preoperative investigations include liver enzymes, bilirubin, albumin, alkaline phosphatase, bleeding and clotting times, and hepatitis antigen tests. Careful handling and sterilization are essential to prevent disease transmission during surgery. Management of hepatic disease includes avoiding anesthetic gases metabolized in the liver, correcting coagulation deficiencies with IV, vitamin K, and plasma transfusions, and monitoring blood volume, cardiac output, and urine composition. Potassium supplementation is provided during fluid replacement. Precautions and sterilization techniques are used to prevent transmission in hepatitis carriers. Oral manifestations such as hemorrhages, petechiae, jaundice, and gingival bleeding may indicate liver dysfunction. Diabetes mellitus is caused by insulin deficiency and classified into type 1 insulin dependent and type 2 insulin dependent. Optimal blood sugar levels must be maintained during and after surgery to prevent hypoglycemia, hyperglycemia, and ketoacidosis. Diabetic patients are prone to infections and may have additional complications such as renal failure, cardiac disorders, and vascular disease. Preoperative investigations include blood sugar, glucose tolerance, renal profile, and urine analysis. Diabetic patients require careful management during surgery. Blood and urine sugar levels are checked on the morning of surgery. A sliding insulin scale is used intraoperatively based on sugar levels. Broad-spectrum antibiotics are given pre- and postoperatively. Monitoring prevents ketoacidosis and hypoglycemia. Shift the patient to regular oral feeds and anti-diabetic medications as soon as possible. Signs of hypoglycemia and diabetic ketoacidosis must be recognized and treated promptly. Thyroid disorders are divided into hypothyroid, euthyroid, and hyperthyroid. Euthyroid patients pose no surgical risk, while hypo and hyperthyroid patients require postponement of elective surgery until euthyroid status is achieved. Hypothyroidism leads to bradycardia and poor stress response, while hyperthyroidism causes tachycardia and heat intolerance. Preoperative investigations include thyroid hormone levels, serum electrolytes, and thyroid scans. Assessment of thyroid function before treatment includes establishing the type of disorder, checking for cardiovascular disease, and obtaining baseline hormone levels. Elective treatment is deferred if symptoms are present. Monitor vital signs during procedures, use caution with epinephrine, and minimize stress. Appointments should be brief and treatment discontinued if symptoms arise. Hormone replacement or antithyroid drugs are continued as prescribed. Adrenal disorders include Cushing's syndrome, overproduction, and Addison's disease, underproduction. Cushing's syndrome causes diabetes, hypertension, and poor wound healing, while Addison's disease leads to adrenal insufficiency. Patients on steroids for more than 2 weeks within a year are considered at risk. Preoperative investigations include renal profile, serum electrolytes, blood sugar, platelet count, and coagulation profile. Management of adrenal disorders includes continuous monitoring of vital signs and intravenous corticosteroid supplementation to prevent adrenal crisis. Fluid and electrolyte balance is maintained, and blood sugar levels are monitored. Glucocorticoid supplementation is adjusted based on surgical stress, with minimal, minor, and severe procedures requiring different doses. These steps help prevent complications and ensure safe surgical outcomes. Neurological disorders include cerebrovascular disorders, seizure disorders, chronic respiratory disorders, and head injury. Maintaining adequate cerebral perfusion and controlling seizures are key concerns. Patients with cerebellar infarcts, aneurysms, and arteriovenous malformations are high risk and may be contraindicated for surgery. Preoperative investigations include skull radiographs, CT, MRI, EEG, and liver function tests. Management includes continuing anticonvulsant therapy until the morning of surgery and administering intravenous anticonvulsants intraoperatively. Postoperatively, patients return to their normal dose as soon as possible. Avoid hypotension and hypoxia and maintain adequate cerebral perfusion. IMF is avoided in neurologically disoriented patients, and delayed surgical fixation is considered to reduce meningitis risk. Disorders of the hemopoietic system include anemias, leukocyte disorders, and coagulation factor abnormalities. These conditions predispose patients to prolonged bleeding and increased infection risk. Preoperative investigations include complete blood count, bleeding and clotting times, prothrombin time, partial thromboplastin time, coagulation factor assay, platelet count, and liver function tests. Blood counts are built up to normal values before surgery, and broad-spectrum antibiotics are used. Management includes avoiding trauma to tissues, achieving complete hemostasis before wound closure, and monitoring hemoglobin and blood counts intra- and post-operatively. Blood transfusion is performed as needed, and systemic oral coagulants like vitamin K are used post-operatively. Medications that exacerbate underlying conditions are avoided, especially in agranulocytosis. Blood products are tested for HIV, hepatitis B and C before transfusion. Immunocompromised patients include those with deficiencies in cell-mediated or humoral immunity, neutrophils, and complements, as well as those on immunosuppressive drugs or suffering from chronic conditions. These patients are highly susceptible to infections and require broad-spectrum antibiotic coverage. Preoperative investigations include blood count, liver and renal function tests, serum proteins, blood sugar, urine analysis, and chest radiograph. Management is supportive, with constant monitoring of vital parameters. Autoimmune disorders include lupus, scleroderma, collagen disorders, rheumatoid arthritis, Sjogren's syndrome, and polyarteritis nodosa. These patients may have cardiac, renal, and bone marrow impairment, contraindicating elective surgery. Operate during remission phase when possible. Long-term corticosteroid therapy requires precautions to prevent adrenal insufficiency. Restricted joint flexibility may complicate intubation and ventilation, and delayed wound healing is common. HIV-infected patients require special precautions in oral surgery. Oral lesions are early indicators of HIV infection and immune suppression. Lesions are classified into 3 groups based on association with HIV. Early diagnosis and counseling are critical to control virus spread. Testing includes ELISA, rapid tests, and Western blot. Management protocols focus on CD4 count and viral load, with asymptomatic patients eligible for routine care and symptomatic patients requiring emergency surgery only. HIV testing and counseling help patients make informed choices and prepare for test results. Pre-test counseling explores knowledge, potential exposure, and testing process. Post-test counseling helps patients cope with results, plan for the future, and decide on disclosure. HIV is susceptible to heat and common disinfectants, making infection control feasible. Occupational exposure protocols include immediate washing, reporting, and starting post-exposure prophylaxis within 2 hours. Dental treatment for HIV-positive patients is guided by CD4 count and viral load. Asymptomatic patients with CD4 is greater than 500 can undergo routine care, while those with CD4 is less than 200 require emergency surgery only. Periodic examination, bacterial plaque control, and simple prosthetic treatment are recommended. Antibiotic prophylaxis is used for septic foci, and oral lesions are managed with appropriate therapy. Infection control measures are strictly followed in the operating theatre, personnel, instruments, and laboratory specimens. Radiation therapy involving the oral cavity and salivary glands causes complications such as mucositis, loss of taste, xerostomia, infections, radiation caries, osteoradionecrosis, and trismus. Management includes oral hygiene, preventive dental care, and restorative procedures. Before radiation, extractions are performed only if necessary, and an interval is maintained before starting therapy. During and after radiation, mucositis is managed with mouthwashes, and dental extractions are minimized to prevent osteomyelitis. Daily topical fluoride applications help control caries and hypersensitivity.